Thanks for joining us on Not Boring CEs, where we don't think you should be bored to death while getting your continuing ed. Keep listening here, then hop over to notboringces.com to get all your online CE credits. All right, y'all, let's get to learning. Beth Brawley is a licensed professional counselor in St. Louis, Missouri. In 2013, she began pursuing specialization and utilizing evidence-based treatments with individuals struggling with OCD, anxiety disorders, and body-focused repetitive behaviors. Beth has been running her private practice, Life Without Anxiety LLC, since 2015, as the goal of utilizing evidence-based practice is to live a life without anxiety making our decisions for us. She's presented yearly at the International OCD Foundation's annual conference since 2015 and completed the Behavior Therapy Training Institute through the IOCDF in 2016. Beth has also presented at the Trichotillomania Learning Center for Body-Focused Repetitive Behaviors conferences in 2017 and 2019. She also presented at the Anxiety and Depression Association of America's conference in 2023. Beth is an adjunct professor at Brown School at Washington University in St. Louis, where she teaches exposure and response prevention skills labs and cognitive behavioral therapy. Beth is a co-founder and co-president of the OCD Missouri, the Missouri IOCDF affiliate. Welcome, Beth. Welcome back to Not Boring CEs. I'm your host, Allison Puryear. I'm here with Beth Brawley, and we are talking about evidence-based treatment for OCD. I'm super excited. I don't know if this is accurate or not, so I'm going to ask you, and it's okay if you don't know. Is there an increase in diagnosis for OCD? Like, has there been an increase in it, or do you know if it's remained fairly steady over time?
I would say, now I'm not pulling from research here, but I would say that there's an increase in diagnosis only because the treatment's relatively new. I think it started to be developed in the 70s. And so the more we know, the more we can identify, oh, this person, actually is displaying OCD symptoms. But before, we might have just labeled them as, just a highly anxious person.
Right.
And like the more research the OCD community does, the more subtypes, I don't even want to say that we're discovering, but perhaps we're discovering are a thing. And so then people are, oh my gosh, I identify with that. I just didn't know that was a part of OCD. So there's a non-answer for your question.
Yeah. I just feel like anecdotally, I know a lot more, like, especially like friends' kids are being diagnosed at a rate that I don't remember before. And I don't know if that's because of different kinds of stressors these days and different kinds of ways of dealing with stressors leading to OCD, if that's just like the way the genetics are shaken out right now, or what, or if it's just like more informed providers who are recognizing.
I mean, who knows? I'm curious to see the research that's hopefully coming out with an increase in contamination fears and contamination OCD given COVID and the experience that has been. So I'm curious about, the genetic component was there, and then that was the spark that lit the fire, and, what we'll see moving forward.
Yeah, absolutely. Well, let's just start with basic, like, understanding what OCD is, what it's not. Let's just lay a good foundation for folks.
Okay. I love talking about this. I'm super excited about this. Okay. So OCD is obsessive-compulsive disorder. So it's a mental health diagnosis, and we can kind of break it up into two kind of symptoms, if you will. So first we have the obsessions. So these are unwanted, intrusive thoughts, images, or urges that pop into our awareness. They are ego dystonic, so we don't want to have them. They create a lot of distress. They go against who we are at our moral, ethical core. And now that I've experienced this very distressing, unwanted thought, I have the compulsion come in, or the urge to compulse. And a compulsion, in terms of like lingo here, compulsion can also be called a safety behavior or a ritual. But a compulsion is something that I do now in order to get rid of the distress and the anxiety. OCD lives in the negative reinforcement cycle. Starts with that intrusive thought. I have a worry. Oh my gosh, that is a really scary thought. I feel anxious. No human likes to feel anxiety, or maybe there's fun anxiety like roller coasters or skydiving, but that's not obviously what we're discussing. We don't want to feel that level of fear, so we do something, some safety behavior, some ritual in order to get rid of that anxiety. What happens for the individual that has OCD is that it then leads to some temporary relief. If I'm worried that I'm going to snap and like a harm OCD example, let's say I'm chopping vegetables in the kitchen, I'm worried that I have this really sharp knife in and boom, I'm worried I'm going to stab my partner, let's say. Well, what do I want to do? I'm going to avoid maybe chopping vegetables. I will avoid using knives. I've had people where they would lock up all their cabinets and give their partner the key so that they couldn't, snap and grab something sharp. So what do I do then? Like, that makes me feel better. Now I know it's behind lock and key and I'm not going to stab my partner. But because it's a negative reinforcement cycle, the very next time I'm in a similar situation, my brain is already primed to worry about the same thing. So it just, I think about it like a cartoon where there's a snowball rolling down a mountain. It gets bigger and bigger over time. When a client's in your office presenting with OCD, it didn't start the way that it's presenting to you. It's gotten bigger and scarier over time. Also, it's important to note too, all humans have intrusive thoughts. Another example I give is, let's say, we have a human, they don't have OCD, they're driving down the road. They might have an intrusive thought of like, oh, there's a person over there. It'd be so easy for me just to kind of turn the wheel and I could hit them. But I don't have OCD, so that thought is not relevant. It's not meaningful. And so I'm just like, oh, that's odd. I'm not going to do that. And then I just go about my business.
Right.
Someone with hit and run subtype of harm OCD would have a very different experience of that intrusive thought. Same intrusive thought, but because I thought it, oh my gosh, it's relevant, it's meaningful, it's scary. Maybe I'm a danger to society, so I need to do something. I perhaps avoid driving. So, intrusive thoughts are a human thing. Our brains are ever creative, but an individual's experience when they have OCD will be very, very different of that intrusive thought.
I think about that, like people who have a non-pathological fear of heights, like it's not impacting their life in any sort of way. It's not a phobia. And how so many of them have the fear, not that they'll fall off, but that they'll jump off. But it's not OCD because it's not impacting their life. And it's just like, it's the thought they have when they're, on a rooftop bar, not yet drunk maybe, or, like going up a clear elevator or something like that on the outside of a building. But
we have the St. Louis Arch here and they have those windows at the top and, it's like people without a phobia are going to feel uncomfortable looking out and feeling the swaying. Yeah,
absolutely. Yeah. Okay. Can we talk about, so we've got the obsessions, we have the compulsions, we have this like negative reinforcement cycle. Can we talk about the subtypes? Because I feel like in my, I didn't know about subtypes until a good bit after grad school. It was like a CE where I learned about subtypes. So here we go. Maybe this is the CE where other people learn about subtypes, how they are similar to one another and how they are different from one another within this like matrix of OCD.
Yes, I love this question because, it's perhaps a blessing and a curse. Sometimes we try too hard. Where do I fit in? What subtype do I fit in? And other times it can be really helpful of like, oh my gosh, Beth, you just described my experience. Like I feel seen. I feel, like this is treatable. My favorite example for the subtypes with OCD is that Baskin-Robbins. Baskin-Robbins has 31 different flavors of ice cream. And yet it's all still ice cream at the end of the day. And that's with OCD. We have a ton of different OCD subtypes, and yet they're all treatable with the same treatment method. So it's all OCD, it's just different flavors. So some examples of some subtypes. Obviously, I think the one we see the most talked about or maybe portrayed in the world is contamination OCD. And so with contamination, you could have someone afraid of themselves getting ill. You can have someone have contamination with the harm OCD subtype of, I'm worried I'll be come contaminated and spread harm to other people, negatively impact others. We could also have contamination OCD where I'm not worried about getting sick. I'm not worried about getting others sick, but it's just that like feeling of grossness or disgust. It's like, I can't see creepy crawly germs crawling around on my hands, but I can feel them. And now like the more that I'm thinking about it and talking about it, Allison, I'm like feeling it on my hand.
Yeah.
We have, the harm OCD subtype where that's a big umbrella too of the different things that fit into that. You might have a client who's worried about, snapping and becoming a pedophile, harming a child. You might have someone with harm OCD, where the example I gave earlier, I will stab someone else. I can't be around sharp objects. I need to check to make sure that I didn't do something and forgot about it later. Hit and run OCD is pretty common. There's a lot of potholes. There's a lot of bumps out there. Someone might, worry that I hit this pothole. How can I be sure that I didn't, run someone over? And anxiety loves to live in doubt because I could give myself reassurance all day long. No, Beth, you for sure didn't hit someone. And OCD always likes to say, but what if you're wrong? What if you just missed something? So we don't use, I'm getting a little off topic, but we don't use logic to fight OCD because that just it doesn't work. It actually can feed OCD.
Right.
And make it worse. And
because then it fights back harder, right?
Yeah. Oh, totally. Like it's never going to be like, oh, Beth, you got me. You convinced me. Like, of course you didn't do anything. It's so creative. Let's see, what else? We can have more like sexuality OCD or sexual orientation OCD. How do I know for sure where I fall on the spectrum? We can have more scrupulosity OCD. And I like to think of it as a tree with two branches. One is religious scrupulosity. I'm worried that I will, think something or do something and then, lose God's favor. I'll be tormented in hell forever. We can also have scrupulosity that isn't related to religion at all. And that's more of moral or ethical OCD. I have to make sure that I never tell a lie or I never, do something wrong. And again, like with all of these, it's just so frustrating because, well, for a variety of reasons, obviously, but the negative reinforcement cycle helps us out in a lot of other areas of our lives, and it's functional in other areas of our lives. This is the area of our life where we're doing something that works out over here, but it's not working here. And in fact, I'm feeling worse. And the thing about subtypes too, Allison, is that I like to tell my clients, like, there's the whack-a-mole effect. So as we start to go after, like, you come in, you have a presentation, contamination OCD, and let's say scrupulosity OCD, and we start attacking those. When OCD feels threatened, it doesn't want to give up power. So it will, look for, oh, well, let's throw this other thing that maybe they've never even been concerned about before. And now they're, oh my gosh, why am I, experiencing this other thing that's never been a concern for me? And it's, actually like a positive sign. Your OCD is feeling attacked and threatened. And so we would just utilize our treatment method to go after that and not let it grow any more than it already has.
Awesome. I'm thinking about how if you, like when I went to grad school, which was, 20 years ago, but if you were kind of left with the impression of OCD is like, often you'll see it in overly like hand washing, or like you have these like stereotypes of what OCD is.
Yeah.
I imagine if somebody comes into your office for anxiety, they're not self-identifying as OCD or as having OCD, and you don't know about the subtypes, and they say something like, I'm afraid I'm going to touch a child, or I'm thinking about stabbing my husband, or like all these harm to self and others things that we are then required to report. It can get so messy so quickly, so harmful to the client.
Right.
So dysregulating for the therapist who thought they were just gonna like have somebody with GAD in there, and they're like, right. Your report, she's gonna kill her husband. How difficult that can be if you're not aware of what's going on, and your client's not coming in aware either. They recognize the anxiety, but they don't know that there's a name for it.
Yes. And I'm biased just because this has been my specialty, my niche, my entire time of practicing.
Mhm.
Um, you know, but I think that main question being like, is this ego syntonic or ego dystonic? The
Mm.
person who is okay touching a child, stabbing their partner, they're not scheduling a session to come in and sharing, oh my gosh, Allison, I'm so worried about this and it's consuming me. And, like that person's not coming in because
Right. Or they're not disclosing that to you.
right. Like
Mhm.
their urges or their intrusive thoughts work for them. Um,
Mhm.
and it's if this causes you distress, that's telling us something. And that's where
Mhm.
it's so helpful to give psychoed to our clients so that they know, they can like sit and they, oh yeah, this is a thing. Like I've had people say like, oh, so I'm not crazy. It's like, no, we're not. No, you just have OCD and we'll attack it together. But yeah, I think that's where, and I can put a plug in, they're not paying me. I can put a plug in for the International OCD Foundation's website,
Mhm.
where they have a huge list of the different subtypes and different ways that you can see that manifest. Because I think, Allison, like you're saying, even if you're not an OCD specialist, it's so important to be aware that this is a thing
Mhm.
and these are the ways that you might see it manifest in case you do like either need to refer out or to work in conjunction with an OCD specialist. I've done that many a time. Another therapist like will work on with the eating disorder and I will work
Mhm.
with the OCD piece. And,
Mhm.
that can be a really beautiful thing, but it can't happen if we don't know, you know, what those really scary ego dystonic thoughts are.
Yeah. I'm thinking too, like differential diagnosis stuff. As somebody who's been working in eating disorders for so long, there are a lot of OC traits amongst my
Mm-hmm.
clients who don't have OCD. How do
Yes.
you do you have a quick trick for being able to parse out without breaking out the DSM? Like, are there tells for you in a session of like, okay, these are traits that are driving your behavior to some extent, but not enough that it's full-blown OCD?
Ah, well, I like to look for, I mean, we know there's a high comorbidity between eating disorders and
Mhm.
OCD.
Yeah.
I think, there's some kind of similar tenets or structure, if you will. Perfectionism is
Mhm.
hugely intertwined in both diagnoses. Guilt. I like to say my clients have an overactive guilt muscle. What
Mhm.
does this thought mean? I did something bad. I thought something bad. Over responsibility. I mean, that can be a component with both eating
Mhm.
disorders and OCD as well. And then having extremely high standards, which I think really back to the perfectionism. High
Mhm.
standards, that could be a really functional thing. I like to kind of parse out, are we striving for excellence or are we striving for perfection? We really
Mhm.
can only attain one of those. Um, so yeah, I would look for like, oh, it makes sense that you feel like overly responsible for having these thoughts. Let's explore that more. What does that mean about you or what do they mean to you?
Mhm. Yeah. Okay. I'm thinking too about like OCPD and
Mm,
being able to parse that out in assessment. How do you do that?
yes. Well, first off, I would just like to say whoever named it just set us up for confusion.
Yeah, totally.
So obsessive compulsive personality disorder, if you quote unquote have one, it doesn't automatically mean you have the other.
Right.
You can have someone who experiences both.
Mhm.
But with OCPD, what I think about is that the behaviors they're doing are not distressing. They are okay with it. It feels functional, it feels helpful, it feels sustainable. That doesn't mean they are. And it can be very unhelpful, very disruptive. I think, I've only had a handful of people come in with OCPD, and each time they were like, I'm only here because my partner is threatening to leave
Mhm.
because I do these things, but I don't understand why everyone doesn't do these things. These things make life like make some sense out of life or whatever. But when we get into it, it's like, oh, that's actually not incredibly helpful. And there's no morality here. You're not doing something right or wrong.
Mhm.
An example, um, I had someone who throughout the year they would save all their receipts,
Mhm.
everything they bought. And then at the end of the year, they would make an Excel spreadsheet. And I asked, what's the function of this? What's this, what's the intention of engaging in this? And it was you don't do this, Beth? Like, this is a helpful thing. And it wasn't because of budgeting. It wasn't because of anything like meaningful in terms of finances, but it was something that they just felt was responsible and good to do. And so, I'll ask my clients, like, are you okay with that? Because if you're okay with that, like, I'm not here to tell you stop doing that. But that would fit more in line with the OCPD. They were okay with it.
Yeah. So it's more that like egocentric experience.
Right.
So it's driving everyone else crazy, but not you.
Yeah. Like you can say like, oh, that looks like OCD, but there's no distress. Like you said, egocentric, they're okay with it. Other people are not okay with it, but they are. So
yeah. Okay. So thank you for taking us down a differential diagnosis path. I just asked you about it. I was like, this, yeah. So can we get into treatment? What that looks, what like effective evidence-based treatment for OCD looks like?
yes.
Yeah, let's go there.
Yeah. So currently our gold standard treatment method for OCD is exposure and response prevention, one of the many family members of CBT. We know that cognitive behavioral therapy, hey, I love it. I teach it. It's great. It's not enough though for OCD. So we need that extra specialized, really niche treatment. So ERP is, I like to say, 2 steps: exposure and then response prevention being 2 separate kind of entities. They're already being exposed. They're out there living their lives. They're living with their brains. So they're already being exposed to their triggers and their thoughts. But the reason why exposure on its own is not enough is because of those compulsions or the safety behaviors. So the response prevention piece is like that huge, like robust part of the treatment of learning that they can resist their rituals or safety behaviors, have tools to ride out that wave of anxiety, and see that, our brains can naturally habituate. Typically, perhaps not as quickly as if I were to go compulsively, like seek reassurance or wash my hands or do something like that. However, over time, I can kind of move on from those feelings of distress faster, because when we trigger ourselves, when we expose ourselves over and over and over, we are having the opportunity to learn something perhaps that's very new. I'm learning my anxiety is a liar. Maybe it overestimated the probability of danger. And so that thing I thought was super, scary and dangerous, now I can see that like, oh, sure, that has been scary to me, but it's actually scary safe, not scary dangerous, I like to say. And then, oh, did I lose my train of thought? Here we go. Oh yeah, but I learned that, perhaps anxiety overestimated the probability of danger, or maybe the thing I'm worried about is more realistic. I've treated people and their fear was that they'll get the common cold. And, is that something that's realistic to get? Sure, it's called common for a reason. But the way their anxiety was lying to them was saying you can't tolerate that experience, either of having a cold, or you can't tolerate the uncertainty of if it'll happen or not. And so there are a few different ways that, anxiety is a liar. And so with ERP, we're learning that these things we felt incapable of doing, or we felt we couldn't tolerate, are actually tolerable experiences, and something that, I can learn that thoughts are not equivalent to actions. I can have a thought of like, oh, I'm gonna, what if I punch that person? And yet I'm still in control of if I punch them or not. And so that's something that OCD would never offer me as an option. And so that's where the ERP would come in. And that's ERP in a nutshell. Very, very small one.
I'm thinking about the difference between like treating phobias, which doesn't have that response prevention piece. Like it might just be like, I did like, for some reason, a good bit of phobia treatment like 18 years ago, maybe, as a generalist in a agency. Somehow a bunch ended up in my caseload. It was great fun to help people like move up their fear levels of the things they were scared of. And like we could take field trips. It was wonderful.
Oh, yes. I love it.
And subjective units of distress and things like that. Like, what are the components of ERP clinically? I mean, I know you're not teaching us how to do ERP in here, but I mean, are there subjective units of distress you're checking in with? How does it look in session?
Totally. Yes. So I love a good SUD scale.
Uh-huh.
And so, I'll ask, where's your anxiety, or how worried do you think you would be if you did blank exposure without, engaging in whatever it is
Mhm.
that you have the urge to engage in? A cool thing about ERP is that, historically it's been very hierarchy focused. We have
Mhm.
our SUD scale, let's say, 0 to 10, 10 being the worst anxiety in the world. And I ask you, hey, Allison, how difficult would it be for you to, go make that phone call and ask a silly question to Target or whatever? And
Mhm.
you're like, oh, Beth, that would be like a 7 out of 10. And we put that on the hierarchy and we come up with a bunch of different options. That's great. That's effective. We also, what's fun, I say fun, what's fun in the world of OCD therapy is that we're moving kind of away from that. It's called inhibitory learning theory, or inhibitory learning method, because what we're realizing is that life doesn't always happen on a rigid hierarchy that we can then say, okay, world, I'm ready for 3s, and now I'm ready for
Mhm.
4s. And again, that's great to do in treatment, and it's workable and doable. There also is something to be said about how much power someone gets from, I like to think of it like a claw machine or a grab bag. If we, come up with all these different ideas for exposures and then say, are you up for just randomly having one, assigned to you? It might be a 3, it might be a 7, who knows? That mirrors more of what real life looks like.
Mhm. Mhm.
And so there's power in, oh my gosh, out of the grab bag, I pulled this 7 out of 10, and that just feels super scary. But you know what? I've seen that this is effective and I can do this. So let's go do that thing. Perhaps I learned I could do more than I originally thought I was capable of doing.
Mhm.
Perhaps I learned that, that thing that was like super big and looming and I was dreading it actually turns out like it was tolerable and manageable, and that bad thing that I was sure was going to happen actually didn't happen. Or again, if it did, I handled it.
Mhm.
um and so with that, like, I'm always curious like where your anxiety level is. And we can also say, perhaps I don't have to rigidly structure my treatment according to, okay, am I at an okay level of anxiety? It's like,
Mhm.
one of the kind of the myths of exposure therapy is that like it's intolerable. um Anxiety is not dangerous. It can feel dangerous. We don't like feeling that way. But I'm thinking, how could evolution equip humans with an alarm system for threats that actually is a threat in and of itself? And so
Mhm.
we can learn that I can experience something, I can purposefully face my fear and actually be okay, actually come out stronger, actually, come out of it with more data, more information that I had moving into it. I'm
Mhm.
not sure if I answered your question specifically. I got a little on a rabbit hole, but I do love a good
Yeah,
rabbit hole. So
me
I'm okay
too.
with
I
that.
love it. I'm wondering too, like, how does it work with, like, it's trickier with some obsessions and compulsions than others, right? Like
Sure.
cleanliness, for instance, or like that one is maybe easier during not the peak of COVID than something like pedophilia.
Yes.
Like, how do you figure out a hierarchy that is not gonna get somebody on a watch list?
Well, right, right. That's why we don't do gratuitous exposures. I always tell
Uh-huh.
my clients, like, I am willing to do everything I ask you to do. And I don't mess around with my life. And so I'm not going to go do
Yeah,
something puts me on a watch list. I'm not going to ask
right.
you to do that too. So I'm glad that you're bringing this up, because that can, I think, it would be safe to assume that if someone feels like that, like, well, I can't test this out, so what's the point in treating it? Like, is this untreatable? Do I just have the one thing that can't be treated?
Mhm.
Like you said, some things we can test out. Beth, I'm worried that if I sit on the floor in your office today, I'm going to get the stomach flu. And it's like, okay, well, I'll see you in a week. And so I guess we'll see, if you have a
Mhm.
stomach flu, just let me know. We won't, we'll cancel session. Um,
Mhm.
but there are some things like, some harm OCD subtypes, more like existential. We can't kill somebody, have them experience the afterlife, and then come report back to us. So
Right.
for those, exposures that, or fears that are really untestable, the response prevention piece is to live in line with our values. So I can give an example of more the
Yeah.
pedophile OCD piece. And obviously for HIPAA reasons, we're making some changes to this.
Yeah.
But in the past, I had someone, they had a new baby and they loved this baby. Obviously, they were obsessed, pardon the pun, with this baby. But their OCD said, if you are around them, like you might snap and do something harmful to them, like you might molest them. And so for them, they had started to avoid changing the baby's diaper. They had started to avoid holding the baby, putting the baby down, really doing any of the things that the parent needs to do. And so it was causing a lot of pain. They didn't get to spend time with their baby. Their partner was feeling overwhelmed and stressed with having to do all the things. So for them, I'm not going to ask them to harm their baby. I will ask them to pull back on the other things that they've been doing, like avoiding, like perhaps reassurance seeking, asking, having their partner, stand beside them while they change the baby's diaper so that they can make sure if I do something bad, my partner will stop me, right? And so that was reassuring to them. So we had them pull back from needing their partner around when they were bathing or changing the baby. And then checking is a big one, like internal checking. And what we know about what's called the groinal response, if I'm checking my body to see, oh, do I feel aroused at all? The more I think about it, I like to tell my clients, and this is an important psychoed piece too, because your client might have been doing this, and then because of just basic wiring and plumbing, they can feel aroused, but there's no meaning to it. But if you have OCD, OCD says, there is meaning to it. So, oh my gosh, now you are feeling aroused and you're around your baby, like you are a monster and that's your evidence. But it was really, kind of becoming a self-fulfilling prophecy of feeling aroused because I was so, compulsively in my head checking to see if I feel that way. So those are the things, we have them create exposures that are in line with their values. For this person, they identified, what's the parent I want to be? The parent I want to be is involved and helpful and hugging and loving. And the partner I want to be is helpful and loving and balanced. And so that's how we can create exposures. Take baby out by yourself, rock baby to sleep, give baby a hug, things like that. We're not actively having people do things that are harmful.
Wonderful. Okay. I'm thinking about more differential diagnosis stuff based on that. Like I'm thinking about like perinatal mood disorders, and like perinatal anxiety and how that might sometimes look a lot like OCD, or OCD may look like perinatal, or they may just, be comorbid.
Yeah.
So how I'm thinking about our perinatal folks out there, how can they get more clear on if it's perinatal anxiety or if it's OCD or if it's both?
Well, the good thing is that if we're going to use ERP across the anxiety spectrum. So
Got it.
GAD, social anxiety, postpartum anxiety, postpartum or perinatal OCD. And we do like to, let people know that, and the non-birthing partner or spouse or whoever they are can also have perinatal OCD and they didn't even give birth. And so that can impact, like I've seen this in a lot of partners where they're like, I don't understand why I'm worried about this. Like I didn't have the baby, so I shouldn't be having this experience. And, the good and bad news is that it doesn't pick and choose. It's just there for everyone. But regardless, we're going to use exposure response prevention because there are things that they're doing. And even if it's just avoidance, there's things that they're doing in order to kind of get through their day, get through the distress that we can then help them learn and see that they can have a different experience.
Okay. What's the typical, if there is a typical length of treatment for someone with OCD with ERP?
Yeah. And I know believe there's stats on this, very specific research on this on like the IOCDF website. I don't know the numbers off the top of my head. But it's relatively, I like to say you can get out of seeing me as fast as you want. I'll have people come in, Allison, where they're like, Beth, I have, this OCD, I researched it. This is what I have. This is what I want to work on. I'm not really curious about anything else going on. I don't want to process anything else, just this. I'm like, great, I'm here for it. We'll do very, structured ERP and get them out there living their best life just as soon as possible. Other people are, hey, Beth, I have this OCD. But since, I don't live in a vacuum, OCD doesn't live in a vacuum, all these other places of my life are impacted by it. Or,
Mhm.
there's other things going on outside of OCD that I'd like to address, and I'm here for it. And so with that, we're going to tackle the OCD while we're also working on whatever other piece of work you want to do. And those people may stay around longer. I've had people, in fact, they started with very specific, just ERP, just to want to work on OCD. And then after they got through that, they were like, oh yeah, well, there are other things that I would like to address. And so we're here for it.
Mhm.
I like to say I'm a therapist first and foremost, but then I also went on to get extensive training in OCD and anxiety. So we don't just have to, address that,
Mhm.
and just really taking that holistic approach to whole human.
Yeah. Are there any diagnoses that are contraindicated for ERP?
I don't know.
Probably nothing common then. It's not, I mean, you'd be like, yeah, depression, no, don't do it. But if that was so.
Right, right,
Mhm.
right. Yeah, no, I wouldn't, maybe I'm wrong. But
Mhm.
yeah, like you just said, nothing is popping to mind.
Okay, cool. So for those of us who are not ERP trained, how do we know when to refer out versus when we should bolster our competency around ERP
Mhm,
for OCD?
mhm. Great question. And I first and foremost would say, like, if you're here, you are bolstering your competency about ERP and OCD. So I obviously don't think it ever hurts to like be invested in learning more about that, even if you're not. Like, I have colleagues where, they've done the trainings, they are ERP trained, and then they're like, you know what, it's not really my cup of tea. So they know what to do, they have the skills, and they can use them in other ways with their clients. But it just wasn't for them. Um, I would say, like, when to refer out. One, if you know your own limits and it's like, I can't talk about people harming their children. Like, I'm not comfortable with that. It's
Mhm.
like, you know, you might be well intentioned, but you could do more harm than good. Then know your
Mhm.
limits, refer out. I would say if it feels like just kind of prioritizing, it's like, wow, this OCD is really a bigger piece of their puzzle right now. It's really causing like the most dysfunction for them. And I don't
Mhm.
feel, I don't know if comfortable is not the right word. Maybe it is confidence. I don't feel confident that that's a piece I can be effective in treating. And I think that's the beauty of, if someone has the resources, being able to see perhaps, this therapist for this thing. And then I also see, I was referred to this adjunct therapist for my
Mhm.
OCD.
Mhm. How often, or what percentage of your clients are on medication at any
Ooh,
given
good
time?
question. I would say or I would say a large part, perhaps maybe like 75%, I would say.
Mhm.
And the thing is, it's like, you don't have to be on medication to do ERP. You
Mhm.
can, but it's doable without. A cool thing within treating using ERP, if someone's on medication and they don't want to be, a cool thing can be to start, stay on the medication, we'll do the ERP. As you go through this journey, as you progress through this, work with your doctor, obviously, but if you're wanting to come down on that or off of that, that's a good thing to do while we're still doing this work, so
Mm.
that, if there is like a resurgence of like, oh my gosh, it's too overwhelming, you can go back on. Or if someone does come off, I think that there's power in seeing that the change in my life happened not because I took medication, because I did the hard thing. I did the hard work. Medication is great. I'm all for it. And medication can't teach us things.
Mhm.
We teach us things, and we
Right.
teach our brain things. And so, if somebody wants to stay on it forever, I'm here for it. I'll support you. If you want to get off, I'm here for it. I'll support you.
Mhm.
As we, do this work, really awesome learning can happen if
Mhm.
that is kind of the route that they're wanting to take.
Yeah, yeah. I just think about how like incredibly dysregulating OCD is, and how for some people, like the medication enables them to do the work. Like it takes the edge off enough that they
Yes.
can do it
Yes.
in a way that for some people without the medication, it's just too much, too overwhelming because they've got the story,
Totally.
right? That it's too
Right.
much for them.
Right,
Um,
right. And so if the medication can slow down our thoughts enough to get me in a place where I can clearly, engage in this work. Awesome. Let's do it.
Awesome. And ERP, is it used with kids as well?
Mm-hmm. Yeah,
Awesome.
I like treating kids with ERP. With kids, you're going to be more behavioral focused with ERP. Yes, I still do cognitive work with them. It sounds different, again, based on age than a fully formed adult. But yeah, we would still use ERP. And that's also really fun because we get to be like silly and goofy and creative. And I mean, we get to be that way with adults too. But with kids, there's just an extra component of like, I don't know, showing them that, they're in grade school and they don't have to live the whole rest of their lives with this fear and anxiety. And it's just really empowering. And frankly, just fun to see.
Awesome. So it sounds like we can bolster our competence much of the time. Like this isn't going to do it, y'all. You need more ERP training than this one CE to work with somebody with OCD. But hopefully this is like your gateway to getting that training if that's something you're interested in. Would you recommend working with a clinical consultant or supervisor as well? Or do you feel like a good training will kind of give you what you need?
I would say you need the good training and then you need the support of supervision or clinical consultation. I mean, I have great respect for my OCD colleagues who, we've been doing this for a while and yet we still seek each other's, consults because there's something to be said about, I don't know everything. It's like taking the humble realist position of, I'm confident that I'm really good at this, or I know what I'm doing. And also I'm humble enough to know that I don't know everything and I am not perfect. So I would say keep doing the trainings and then seek out other minds as well.
Okay, great. So I know like the top down and the bottom up, like there can be a split sometimes in the therapist communities that isn't always kind.
Yes.
And it doesn't always have respect for different things work better for different clients. Like there is validity and healing in both top down and bottom up. And I think exposure therapy is one of the things that gets a lot of heat, not just from the bottom up community, but from some of the other top down folks, because it sounds so bad.
Right.
It sounds cruel on some
Right.
level.
Right.
Can we like dispel some of the myths around exposure therapy?
Yes, please. It's like, you're right. It can be a hot button issue, I think, at times. As therapists, don't we want our clients to feel better? So why are you actively making them feel worse? And it's like, okay, I can get behind like the compassionate place that's coming from. Of course, we want our clients to feel better. And yet, what we know is that anxiety is a safe and universal experience. We will all feel anxious at some point in our lives. So I like to think like our clients are already feeling anxious. Perhaps I'm not making them feel more anxious. Maybe I am. Maybe I'm making them feel anxious in a different way, but they're actually learning that anxiety is a safe, tolerable, universal experience through exposure therapy. And because we don't do cruel, gratuitous exposures, we're doing exposures based in acceptable risk. There's always risk in life. We can never convince ourselves there's no risk, but there can be acceptable risk. And I think that's, to where it comes in. I don't take unnecessary risk with my life. And since I practice what I preach and I'm only going to ask you to do things I'm willing to do myself, there's kind of like that safeguard as well when you're doing effective and ethical exposure therapy. And then another thing I think could lead to, ineffective treatment with this is if a therapist sees their client as being fragile. If I am, sending you the message like, no, don't do that. Like, I don't think you're ready for that. Or like, that's too high on your hierarchy. What am I telling you? I'm telling you, I don't believe in you. I'm telling you that you can't do this. And they've probably already had other people in their life send them those messages, but we, surely know that their brain has already sent them those messages. They don't need us to get on team. You can't do this because you're fragile. people with anxiety are some of the bravest, most courageous, strongest people I've ever met. And especially Allison, I think about, I've had clients come in where they did work with someone before who said, oh, I treat everything, including anxiety. And they're like, well, I have anxiety, so maybe this will work. And Allison, the horror stories I have for you of other therapists just, really making them feel worse, believing that, oh my gosh, your thoughts mean something. How could you have that? How brave and courageous it is of those clients who then willingly seek me out or seek someone else out
Yeah.
and like try again.
Yeah.
Like knowing that there could be the same experience. Like Beth might misunderstand me like this other person did, and yet they're willing to show up. That is amazing. That is not a fragile person. That is a person who is incredibly brave. And I'll always tell them, bravery is not a feeling. It is a choice. I don't feel brave. I feel scared. I'm like shaking in my boots, but I am going to reach out to this new OCD therapist and give it another shot. Like you're choosing to be brave, and that's awesome. They just might not be aware that that is actual bravery and strength.
Yeah. I know that like in the eating disorder field, there are like landmines all over the place that people step in and they don't even realize they stepped in it, like really seemingly innocuous things like, if somebody's refeeding and they come in and they say like, oh, you're just looking so healthy, like healthy equals fat,
Right.
and if you're not trained in eating disorders, like that's a compliment to say you look healthy. Like you think you're helping bolster them. I'm curious what some of those landmines in OCD work might be that I may be saying. I don't know, like any of us may be saying, like not even thinking twice about it.
Yeah. Where my mind first goes, and I'm so glad you brought this up, is reassurance giving. I've had a client in the past describe, I would go see my talk therapist and I would get reassurance from them that, they were they were dealing with like some of the like molestation fears. And so they would go in, not necessarily say, this is what I'm worried about, but get reassurance from their therapist that they're a good person and they have a good heart and they don't, they wouldn't hurt someone willingly. And then they would feel better. I got this reassurance from my therapist, and like, therapists know what they're doing, right? And so then I leave and I feel good. And then over the week, it kind of comes back. I feel worse. Oh, but I go to my next therapy session. I get that reassurance from them again. And then over the week, it kind of, stops being effective. And so I think, we can fall into reassurance that, oh no, that thought isn't meaningful, or like, you would never do that. No, you're a good person. Well-intended. Are those kind things to say to somebody? You have a good heart. That feels good to say and to receive. But for someone with OCD, they might not even realize what's happening, that like therapy has kind of become a compulsion. Without it, I wouldn't be okay. So I have to keep going back, but I don't even feel better. So that can be a landmine for sure.
Yeah. Oh, how interesting of like therapy as a compulsion. What a messy situation for a therapist to find themselves in.
Right. And in fact, something I will tell them at the beginning of treatment too is that they will eventually kind of take on the therapist role. We don't want like Beth assigning exposures to be a compulsion as well. Like, okay, I can do this because Beth asked me to do this, and Beth wouldn't ask me to do something dangerous. And so I'll do this exposure in its like purest form, and I won't go outside the lines. And, great, you did an exposure. That's awesome. You didn't do something wrong here. But we ultimately want you to take on that ownership of, I'm going to create my own exposures in life. I'm going to call out anxiety in my own life to show myself that I can be in the driver's seat, and I don't need someone's kind of sanctioning of, this is okay to do. So that can be another way where if we're the only one kind of coming up with exposure ideas, that could also potentially become a compulsion as well.
I'm wondering about like, so we've got reassurance as one thing that we might be stepping in it. I'm wondering about like trying to rationalize out of it, if that's another one, because I know you mentioned earlier, like you can't rationalize your way out of OCD. If maybe some of the traditional CBT, like replacing the negative thought with a more positive thought that's 100% true,
Right.
How does that usually play out for clients?
Right. And that's where like CBT again is great, but it can, like, if we're getting really stuck in kind of the cognitive restructuring, it's great to do that in ERP as kind of a foundation. You need to know like why this will work. You need to know what you're signing up for. And so the kind of the psycho ed piece is going to look into what meaning are we putting on our thoughts. It's going to sound more CBT.
Mm-hmm.
And then at some point, we have to get to a place of sitting with uncertainty, so if I can do the cognitive restructuring, okay, here are the reasons, why this thought might not be accurate. But then moving to a place of ERP, my favorite word here, Allison, is maybe. So if I have a what if thought, what if blank bad thing happens? Cognitive restructuring might look like, okay, well, here are the reasons why I wouldn't do that. And, oh, well, there's like the overestimation of, danger. And that's one of the things we did at the beginning. We move away from that and we go to maybe that bad thing will happen. Maybe it won't. I'll sit with the uncertainty and I'll tolerate the distress that comes up with that and show myself that I don't have to have a thought and then immediately engage with it.
Mm-hmm.
So CBT is great for that foundational why we're doing this. But then ERP moves to, and this is where we can be a little like silly or goofy or playful with our thoughts of like, oh, sure, OCD. Yeah, of course it's going to happen. Maybe it will, maybe it won't, but I'm not dealing with you right now. I'm not playing with you right now. And then I'm going to mindfully redirect to, actually, I'm going to go eat lunch now because I'm hungry, or I'm going to go outside for some fresh air now and actually, go live my life instead of sitting here playing tug of war with you.
Mm-hmm. I'm curious about like the different, I'm going back to subtypes. I'm just going to ping pong us around.
Yeah.
But I'm thinking about subtypes and if there are certain subtypes that have better prognosis versus worse prognosis. If some of the compulsions, like how they fit into our culture or society, if that makes it easier or harder with like the social norms and pressure of behaving a particular way. Does that help or does that hurt? I have a lot of questions.
I have and please remind me if I'm like missing one of your questions in my answer. I have had people say, I was out in public and I really felt compelled to engage in blah, 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 compulsion, but like, I didn't want to look weird. I didn't want to be embarrassed. And so I was able to resist. And like, we could work on the idea of like being embarrassed is a bad thing, or like, work towards like, who cares what people think of me? But if that in that moment helps you, not engage in said behavior, that isn't helpful for you, like, okay, great. Let's take the win where we can take the win. Allison, what's the first thing that you asked? I had something come to mind.
About
subtypes.
Yes, subtypes, and if their prognosis with different subtypes.
I would say no. Again, I like to think of it's all ice cream. So it's all like rooted in their core fear, which we can attack with ERP. With one little caveat is that the feeling of disgust in like contamination OCD, for example, that one typically is harder for somebody to habituate to. That one kind of like, we do have research for this, like this has been my experience. It's just kind of harder to move away from that like icky, gross, like bleh, feeling. Harder to habituate to that, or it takes longer than perhaps a fear of, I'll touch Beth's doorknob handle on the way out and then I'm going to get sick over the next week. Like that is something that you could habituate to more quickly. But with disgust, I mean, it's not that we say, oh, this one's harder to habituate to. Sorry, Charlie, there's no hope for you. If our goal is always led by values-based living, then what I can show myself is that I can tolerate feeling gross or disgust while I go live my life according to my values. We get very acty.
I was going to say, going to weave in some act.
right. All the time. So it's like that's the learning. So perhaps the learning is not that like, oh, it'll go away, that icky feeling, it'll go away in 20 minutes. Like, perhaps not, but you learned something that before you were avoiding living your life, and now you are feeling that feeling and living life. And that's the whole point. So you're changing your experience, even though potentially still feeling the same way.
Yeah. How do clients, like, I'm imagining most clients when they're finally like, they're coming in, they're seeing an OCD specialist, they're like ready to tackle this thing. And then they're told, you may still feel that same level of disgust. You're just going to handle it better. Like, it's the more realistic answer of like, we're not going to wipe this out. You know, you're not going to always, you're not going to start licking toilet seats. You know, like this is, it's not changing your experience of disgust, but it will change your experience of life while disgusted.
Yes.
Does that take the wind out of their sails or their motivation to get into the work? Or is it still compelling enough for them that they'll be living their life unhindered?
Yeah. Well, and this is just my experience.
Mm-hmm.
But if when we're able to frame it in a way of maybe you'll still feel that, maybe you
Mm-hmm.
won't, maybe you will habituate. I just want to give you a heads up. If they're able to accept that and see that, okay, I could potentially still feel that way and yet have an easier time moving through my day or moving through my life, or I get to engage with my life. Like I'll be in a place where I can engage with my life more, and
Mm-hmm.
perhaps this feeling won't hold the same power or weight. I think that can still be a compelling argument.
Mm-hmm.
And the whole goal, and this, I named my practice Life Without Anxiety because naming it Life Without Anxiety in the driver's seat of your life doesn't really fit on a
It's a
business
long
card that
URL.
well.
Yeah.
Yeah. So the goal is not to live a life without anxiety. The goal is to live a life without anxiety, calling the shots for us, making decisions for us,
Mm-hmm.
because we know like anxiety in healthy doses is helpful. It's our
Mm-hmm.
natural alarm system. So we're not coming at this looking to get rid of this, wipe this out, like you said.
Mm-hmm.
But we're looking at this from a place of, okay, I'm a human and a human will experience anxiety, but I can be a human that experiences anxiety in a much different way.
Mm-hmm. Is
It's
there,
like,
well, go ahead.
I was just going to say, it's the difference between like living with fear versus living in fear.
Mm-hmm.
And so fear is not kind of our guide now, while we acknowledge that it can still be in our experience.
Right. Is there a fair amount of psychoed you do for partners or parents in order to help them have like manage their own expectations, basically?
Yes, that is always helpful when we can pull the support system in to session into the process. And, largely because if they have a loving partner, or if they have a loving, parent or whoever, that person is probably going to have to do their own ERP in allowing
Mm.
their loved one to feel distressed and not swoop
Oh.
in and save them from that.
Mm-hmm.
Oftentimes, and this will be, some of the things that we ask and talk about, what are the kind of accommodating behaviors that the support person has been doing, and acknowledge and validate that comes from a place of love. When we love someone, we don't want to see them suffer.
Mm-hmm.
And so, having the partner or parent or whoever be able to ask questions of, oh, so actually, like, they need to be uncomfortable, like they need to do the scary thing, and I need to step back and I need to offer support without being accommodating. Giving them that information can help the treatment process, move along more quickly or smoother, if we don't have, partner or parent kind of undoing the work through accommodation.
Mm-hmm.
I also always tell them, do not force anybody don't force your person to do an exposure, and don't surprise the person with an exposure
Oof,
unless
yeah.
they've given their consent.
Mm-hmm.
I've had a couple people where we worked together and it was awesome. And then towards the end of their treatment, I asked, hey, would you be up for a surprise exposure? You don't know what it'll be. You don't know when it'll be. But, perhaps maybe next session or the following one, would you be okay with that? And anytime I felt like it was clinically relevant, you've had the rapport established, they've, seen that this works, they've been okay with that. And that also can mirror real life, where exposures just pop up, but we don't have their support people force them or surprise them.
Right.
That doesn't bode well for trust or the treatment process as a whole. So it's very important to give them that psychoed piece as well. Like what your person's signing up for might be hard for you as well.
That's such a good point. Because I can imagine like a well-meaning spouse, like they've seen their partner make such great improvement. And there's this thing that they've been wanting to do with them, but they haven't been able to. And they're like, you've graduated to this, I've decided. And that being really rough for both of them.
Right. Right. You worked on your fear of flying. Hooray, you're awesome. Like you're in a better place. I bought us tickets for next week. Like, don't do that.
Yeah. Coming from a place of love. I mean, it's the same thing with accommodation, right? It always comes from a place of love. It's so hard to watch your loved ones suffer. It feels so good to celebrate your loved ones' growth and accomplishments. And I guess this is the rainbows and butterflies version. There are probably a lot of things being done out of ignorance and being sick of the person not doing what they want them to do or whatever, whether it's a parent or a partner. That probably does happen a lot too.
Right. Or parents, I've had this experience, parents saying well, if you don't do your exposures, then you don't get screen time, or take away, you can't hang out with friends. I'm like, well, that's not going to help them want to do this anymore. That's not a natural consequence. And again, it's that can really kind of erode not only trust in the parent, but trust in the process. Why would I bother if I'm just going to get, things taken away? Because exposure is hard. And I always tell my people, don't try and be perfect with this. You can't. We're going to come up with amazing exposures, and, you're going to come back next week, and I don't want you to do 100% of them absolutely correct all the time. That's not real life.
Right. And it's also probably more rooted in people pleasing or trying to do it perfectly. Than the process itself. Yeah.
Right. I mean, it's a great exposure. I will tell them, make a mistake, do something wrong, let someone down.
I felt that last one. No, thank you.
Bye, Beth.
Yeah.
But these, the compulsions that they've been doing have felt, and since feelings aren't facts, have felt helpful. And so we're asking someone to give up something that felt like it saved them. We're also asking people to give up things that have become perhaps habitual. They might not even realize all the times that they're doing it. And so, there are going to be times where it's oh, crap, I know I'm not supposed to ruminate, and I've just been doing it for half an hour. It's that's where Alice and I love to weave in a lot of self-compassion work with this as well, of, hey, I'm human, and this is a hard therapy to do. It's I'm asking myself, Beth's asking me to willingly put myself in uncomfortable situations and accept it. And this acceptance as a skill is not always zen and roses and rainbows and butterflies. Acceptance can really suck. And so I think, learning to accept that we're not perfect, we are human, we'll mess up on this journey, and that's okay. And in fact, the cool, powerful piece here is that we can help them learn to have a different experience with mistakes and failure. And I like to say in my office, we use the word failure not from a place of morality or judgment. Failure is just data collection. Okay, that was a mistrial. What happened? What was going on? What was I thinking? What was I feeling that led me to blank? And so, learning to neutralize the idea of making a mistake or feeling like a failure is huge. And sometimes I'll say, what if we work on this piece? And they're like, no, failure is always bad. That can't happen. But it can be just so freeing.
Yeah. Yeah. It's interesting because I think probably 99% of people listening, when they hear the word failure, it's an immediate, no, that's an awful thing, right? And
Right,
how
right.
like being in the entrepreneur world, there's this whole mantra of fail fast. Like get into action quickly, see if something works. If it fails, it fails. That's data.
Hmm.
Move
Yes,
on.
yes.
And as somebody who like biggest fear in the world is failure, it's been really like healing in some ways for me
Yeah.
to be like, okay, just feel fast. It's fine. It's all just data. It's fine. Like I
You're
have it
doing exposure
reinforced.
therapy on yourself.
I know. I always, I live my life hard enough that I think there's just always some exposure. Um, yeah. So I think there's this, it's an interesting thing because when failure is just data and it's not personal, it's not moral, we're
Yes,
open to so much more. I mean,
totally. If
there's
I
just
can't
much.
fail, if I can't tolerate even the possibility, what do I get to do in life? How do
Yeah.
I get to evolve or learn? Like that can't happen
Hmm.
unless I'm willing to take, and I come back to acceptable risk.
Yeah.
Um, Acceptable risk holds uncertainty and it holds the potential for failure. So can I change the way I engage with failure and see myself in light of failure? It's a much easier way to live.
I
Not
love
not
it.
easy, 100%,
No,
but
no.
easier.
Yeah, yeah. Because there's just more great stuff to bolster the heart.
Totally.
Yeah.
Totally.
Oh,
Yeah.
Beth, thank you so much. This is such a good conversation. I want everybody, I want to go get trained in ERP, even though
I'm
I barely
biased,
see any
but it's the
clients.
best.
Yeah, this is great. And I appreciate you educating us a lot on OCD as well. Because I think that there's just, for those of us who don't treat OCD very much or at all, there's just so much to learn and there's so much to know. So we do no harm if somebody does come into our
Right.
office and we can make
Right.
the right referrals or we can get the right training in order to support.
Right. Exactly. I appreciate this, Allison.
Yay, thank you. I hope that broadened your clinical horizons. Head over to notboringces.com to get your CE credit. Want to have a not boring conversation with me about your clinical area of expertise? You can apply there too. If you like this conversation, leave us a 5-star review, tell a friend, and be sure to subscribe for future conversations.